This is part 4B in our course in the Foundations of Optimal Brain Performance, focusing on everyday concerns to do with brain function like low mood, fatigue, anxiety and brain fog. In part 1 we looked at the stress response and in particular the role of the adrenal glands and how they can become dysregulated and how that can be behind problems like fatigue and anxiety and so on. In this part we'll move on to the thyroid, and then vitamin D, which though it's not technically a hormone, basically functions as one. And then lastly we'll take a look at appetite regulation and causal factors behind uncontrolled craving. So we'll start with the thyroid gland. It's a small structure in the throat area and it's responsible for controlling body temperature. It does that by managing metabolic rate, or the rate that your body burns calories to release energy. All the cells in the body have thyroid receptors, meaning that they can pick up the messages that the thyroid broadcasts. And that probably gives you a sense of the importance of the thyroid. The only other signal that's picked up by all cells in the body, as far as I'm aware, is vitamin D. Thyroid produces a hormone called T4, which is not actually the active form. It's transported elsewhere in the body via the bloodstream, and then it's chemically converted into another hormone called T3, which is the active hormone. So that means that T4 is it doesn't affect cells, but T3, the active form, is. It does affect cells. Now, the first step in this pathway is a signaling step. It's a signaling pathway rather than a chemical conversion. The thyroid itself is under the control of the pituitary gland, which produces a hormone called TSH, thyroid stimulating hormone. Now, of course, the pituitary in turn is controlled by the brain, and the brain, one of its jobs is to detect the amount of thyroid that's in circulation, and so we have a feedback loop, a little bit like with the adrenal glands. So, of course, things can go wrong, and I think it's better to think of the thyroid system rather than just the thyroid gland, and you can probably already get the sense that there's a number of places in the whole system where problems can happen. And to get a complete picture in terms of assessment, you really need to look at all parts of the system, not just the gland itself. So problems in the system don't necessarily result from damage to the thyroid as a gland, but can also stem from breakdown of communication. So what exactly can go wrong with the thyroid system? First thing to say is that the thyroid system can go either too fast or too slow. Too fast or hyperfunction means too much energy is being created. You'll feel rather hyper, probably too hot and maybe too wired or even anxious, while too slow or hypofunction means fatigue and cold and slowness. Too fast is usually a stage that doesn't last forever, and eventually you'll end up in low thyroid function. Another important point is that problems are really a matter of degree, ranging from full-blown clinical or medical problems to non-optimal functioning of the thyroid. So we're back to this idea of a wide spectrum of health functioning that we've touched on earlier on in the course, with a large grey region between outright disease on the one hand and optimal health on the other. And that's where a lot of everyday problems like low mood and fatigue and brain fog fall. And you can say that this concept applies specifically to the thyroid system. And that means that's an opportunity for a lot of controversy with regard to diagnosing thyroid problems, medically speaking, because really you want to answer the question, is there a thyroid problem? Is there a thyroid disease even? With a yes or no answer. But what you actually have, at least in most cases, at least in the mainstream medical system, is a test, usually of a single hormone, and that gives you just a point on a spectrum rather than a yes or no answer. So it's like asking, if a person is tall, yes or no, and then measuring their height. So you've really got another question to answer. How tall is tall? And ultimately, it's an arbitrary decision, and it's the same with thyroid. It's a question of how much of thyroid hormone is a problem. So in mainstream medicine, it's normal to use the standard 95% reference range. So if you measure the thyroid hormone T4, then you say that the bottom 2.5% have a hypothyroid problem, and the top 2.5% have a hyperthyroid problem. But why 95%? And why not 94%? And what if you're just about here? And what does it mean if you're here and you actually have several symptoms of low thyroid? So in fact, there are a lot of doctors around the world who think that the standard reference range is actually much too wide, even as a medical test. Or another question, which is perhaps more relevant from our point of view, is what constitutes the optimal or ideal range? Now, there's even more room for controversy when you think that problems with the thyroid system may have nothing to do with T4, but could be, for example, to do with T3 or the conversion of T4 to T3. Now, a common cause of thyroid problems, and perhaps the most common cause, at least as far as at least in a medical sense, is when the immune system attacks thyroid tissue and destroys it. And if it goes far enough, then you can be diagnosed with an autoimmune disease such as Hashimoto's or Graves' disease. But you can also have a low level of autoimmune activity that's not diagnosable as a full-blown autoimmune disease. Now, by the way, a common predisposing factor for autoimmune activity is gluten intolerance. And that's important, and we'll come back to that later on in the course. Another cause of trouble is deficiency in the nutrient raw materials needed to make thyroid hormone. And the notable ones are iodine and selenium, and also the amino acid L-tyrosine, which ultimately comes from protein in your diet. So problems with protein digestion or absorption, which are by no means uncommon, could create problems with the thyroid system with a lack of L-tyrosine supply. Another thing that can go wrong is the conversion of T4 into T3. That can run into problems. Now, in Unit 3 of the course on blood sugar regulation, we came across the idea of insulin resistance, where the cells stop responding to insulin. The insulin is there, but it's not having an effect on the cells. And it could be that the same sort of problem happens with thyroid hormone, or even other hormones besides, such as cortisol for that matter. So again, that would mean that the T4 and T3 are there and they can look fine on the test, but they don't have an effect, or at least T3 doesn't have the effect. And the result is the same set of symptoms as you would have if there were no hormones there, or if there were a deficient level of the hormones. So that would be classed as a functional hypothyroid condition. And again, you wouldn't necessarily see it in the test results if you're just measuring hormone levels. Now, back in the introduction in part 1 of this unit, we looked at adrenal dysregulation. And to some extent, the adrenal hormones, such as cortisol, they exert an influence on the thyroid system. And when adrenal function is low, that can sort of pull down the thyroid system function too. So you might have, again, a functional thyroid problem, but not really a problem in the thyroid system at all. Certainly it wouldn't be classified as a medical problem, and again, we'd be in that grey region between optimal health and disease. Now, I mentioned earlier that thyroid is ultimately under the control of the brain, and it may be that the brain can deliberately turn down thyroid function. This may happen as a result of yo-yo dieting. So when you go on a very low-calorie diet, then the body can react to that as though you're in the midst of a famine, and it turns down metabolism as a means of conserving energy and conserving stores so that you can have the best chance of surviving the famine. Now, you may in fact lose weight on such a diet, but then after the end of the diet you may still be stuck with this kind of lowered metabolism or survival mode. So in summary, I think it's possible to have what you might call a subclinical slow thyroid problem, even if your doctors run a thyroid test and found that you're okay, so in that grey region again. And partly it's a matter of judging it by the symptoms, and the main symptoms for low thyroid are fatigue, low mood and depression, brain fog, meaning poor focus and short-term memory and other aspects of cognitive function, weight gain or a tendency to weight gain, and a tendency to constipation. Now, saying constipation may be misleading. It really means slow transit time of food through the gut, perhaps resulting in hard compacted stools, but it may be that you're going to the loo every day and you don't think of yourself as constipated for that reason, but you still have a slow transit time. So when it comes to testing for low thyroid, it's clear that we've got to look at the whole system to get the full picture. So that means measuring all the hormones involved, so TSH, T4 and T3. Now, another thing is that T4 and T3, when you measure them in the blood, and thyroid testing is really a blood test, by the way, T4 and T3 can exist as bound or free, and bound meaning that the hormone is attached to some transporter protein, and in fact most of thyroid hormone is bound and therefore not available for use. So it might be that you have too much bound and not enough free, and that can have problems, or vice versa for that matter. It's also useful to have a look at the antibodies that are markers for the autoimmune damage to the thyroid that I mentioned. Now, that said, I think that the sort of problems that we're focused on, so anxiety and mood problems, etc., testing thyroid, for me, it's not usually part of my first line of testing as a practitioner, but it might be a useful follow-up test. And it's always just worth bearing it in mind if you have the combination of problems that would suggest a thyroid problem. However, there is a useful functional test that you can do at home for free of charge, or at least free of charge if you happen to have the equipment that you need, which is the thermometer. So a functional test meaning that the test is really a test of the effect or the function of the thyroid system rather than any particular component of the system. What you can do is you can measure your body temperature, and the best time being first thing on a morning, immediately on waking, before you've even got out of bed. So it's good to have the thermometer ready by your bedside, and what you need to do is take an average over at least a few days, and longer if you're a premenopausal woman, because your body temperature does vary over your cycle. Normal body temperature is around about 37 degrees C. It's usually a little bit lower first thing on the morning, but anything that's consistently below about 36 is suggestive of at least a functional thyroid problem. I do stress that's not necessarily a clinical thyroid problem. Now, this home test, the temperature test, is called a Barnes test after its originator, Dr. Broder Barnes, and you can find out more about it by searching on the internet for something like Barnes test thyroid, something like that. Let's move on to vitamin D. Now, for historical reasons, it's classed as a vitamin, and of course it is found in food, but functionally speaking, it's a hormone because it's a signaling molecule. And the major source is your own skin, which can make vitamin D in the presence of strong sunlight. But the problem is, at least for us here in the UK, that for much of the time, sunlight even if it's not cloudy, the sunlight is not in fact strong enough because it's too low in the sky. In the winter months, you can't make any vitamin D, and even in the summer you have to be out in the middle of the day and also without any sunblock on. So for these reasons, vitamin D deficiency is very common. There is of course some in food, but it's not really enough to prevent at least a functional deficiency. And if you have dark skin, then your vitamin D production is much less efficient and you're even more likely to be deficient. Now, I already mentioned that all human cells have vitamin D receptors, meaning that they're listening out for the vitamin D message and they're affected by vitamin D, and that's an indication of its significance. The first function of vitamin D that was discovered was calcium regulation and bone health, but in fact it goes way beyond that. There are many more functions. We can't list them all here, but what we can say is that vitamin D works its effects via gene expression. That is, it turns genes on and off. And in fact there are many hundreds of genes that are affected by vitamin D, either directly or indirectly. It's known that vitamin D is strongly anti-inflammatory. Inflammation is a process of repair and healing, but it can become a problem, as we've said in the introduction, if it goes on for too long. In other words, if it becomes chronic. And in fact it's implicated as a mechanism for most, if not all, of chronic health problems, diseases. And that includes neurological diseases like Alzheimer's. So we'll look at inflammation in more detail in a later unit of the course, Unit 8 in fact. Vitamin D deficiency is known to correlate with different chronic illnesses. I've listed just a few of them here that are relevant to our purposes in looking at brain function. So anxiety and depression, and insulin resistance, which we've already looked at earlier in the course, and therefore blood sugar regulation, and diabetes, of course. And as we saw, Alzheimer's is related to insulin resistance, and that too is affected by vitamin D deficiency. So vitamin D's importance to brain function is such that I recommend all my clients check their vitamin D level. And the test is a simple blood test. What actually matters is the blood concentration. And again, like with the thyroid hormone, there's a certain amount of controversy over what constitutes deficiency. And as more and more research evidence comes in, and at the moment there's a huge amount of interest in the research and a burgeoning research effort in this area, it's clear that the optimal level is much higher than what you might call an adequate level, or at least a level that's enough so that you don't get, say, rickets or some bone disease like that. And again, for similar historical reasons, the recommended daily amount is pretty low, but there is pressure for it to rise, and it's also pretty clear that the RDA is a minimum that's really not going to get you to the optimal levels if you are deficient. And in any case, how much you need as a supplement depends on how much you're getting from sun exposure, so it really is quite an individual thing. Now, while it's clear that deficiency is associated with disease, the evidence that supplementing vitamin D helps with disease and is therapeutic is less clear. There definitely are positive studies around, but also some negative ones that don't show an effect. It may be because for the negative ones, the studies, the dose wasn't high enough to bring people up to the optimal blood concentrations, not enough for it to be therapeutic or effective, you might say. So for most of us who don't get regular sun exposure, supplementation is definitely worthwhile, but you really need to test your level in order to judge how much you need, or the dose, and especially the dose needed to reach the optimal level. Vitamin D is in fact toxic at high levels, but you'd really have to take a very high dose to get that far, and it's pretty unlikely, but even so, it's all the more reason to test your blood level. We'll turn now to appetite regulation. It's an important topic because of the prevalence of overweight and the difficulty there is in sustainably losing weight. And it's clear that a big part of that difficulty is appetite regulation. Some people have a constant low level of hunger that never seems to be satisfied and makes it almost impossible to stick with a low-calorie diet. And there are real physiological reasons for that. Now, that said, appetite regulation is a complex topic, and there are lots of influences on appetite, including psychological and emotional ones, but I'm just going to focus here on the biological ones, just for the sake of keeping the content manageable, and of course that's the main focus of this course. So you might guess that hormones are involved. So hormones have an influence on appetite, and actually quite a lot of them. Some of them are produced in the gastrointestinal tract. Probably the best known of these is ghrelin. It's produced when the stomach is empty, and when it's detected in the brain, it creates the experience of hunger. And conversely, ghrelin is switched off when the stomach fills up or when it distends. Ghrelin's not the only GI hormone, but let's just summarize a few practical points about GI hormones generally. First thing, it takes time for the signal of satiety to be generated and received in the brain, maybe 20 minutes at least after the start of your meal. So you need to take that into account, and that's one of the reasons why it's a good idea to eat slowly. Secondly, it's clear from the evidence that protein is the best kind of food for satiety and for having an effect on these GI hormones like ghrelin. So if appetite regulation is a problem for you, then it's a good idea to ensure that you have at least a protein component each time that you eat. Lastly, bulk in the GI tract matters, at least to some extent. If you can fill up your stomach with relatively non-calorie dense food, shall we say, well, that can help. One way to do that is by adding liquids. So, for example, thick soups seem to work better than just eating relatively dry meals. Sugar has a major bearing on appetite. Earlier in the course, we saw that sugar acts in the brain like a drug by stimulating the dopamine-based reward and motivation circuits and creating a fairly immediate feeling of wanting more. It's clear that as a society, we're eating more sugar now than we ever did before. And in our evolutionary past, high-density, fast-releasing sugary foods were relatively rare, and we didn't really evolve the mechanisms to switch off the appetite for sugar at that sort of time scale that we need. So our appetite control systems aren't really equipped to cope with the modern diet and the large amounts of sugar involved, and the large amounts of sugar simply break the appetite system. Now, same can probably be said of artificial sweeteners, which although they might be very low calorie, they also tend to produce dysregulation in appetite. So what it means is that we just have to get used to the idea of minimizing sweet foods in our diet. Now, it must be said that the perfect combination for stimulating the feeling of wanting more seems to be about a 50-50 mixture between sugar and fat. But nonetheless, I think the emphasis needs to be on reducing sugar rather than fat, because it's clear that the sugar is what's doing the damage, physiologically speaking, in the longer term. Now, the question of the sugar versus fat, it's a big one, and I don't want to go too far into it here, but I'll just mention that around the world, traditional peoples have eaten large amounts of fat in the diet without any health problems, but those same groups of people, when they've come to a Western-based diet, they've quite quickly started to manifest the same sort of health problems as we do, such as diabetes and heart disease. So blood sugar regulation is really a key aspect of appetite regulation. In the first place, because low blood glucose levels are a major trigger for appetite and craving. Leptin is a hormone that's connected to satiety. It's actually produced by fat cells, more so when they're full, so to speak, and as fat levels drop, then less leptin is produced. So leptin is secreted into the bloodstream, and it's detected in the brain, and that creates the feeling of satiety, or at least it should do. But it seems that this message doesn't always get through to the brain. For some people at least, the leptin is there, but the brain doesn't respond to it. They don't get the feeling of satiety. In part 3 of the course, when we looked at blood sugar regulation, we looked at insulin resistance, where the effect of insulin is blunted. And it seems that we can have the same sort of thing with leptin. So the result is leptin resistance, and leptin resistant people seem to have a low level of hunger that never quite goes away however much they eat. So what causes leptin resistance? I'll just touch on a few of the best known influences. Firstly, high levels of cortisol, the hormone cortisol. Cortisol is a stress hormone. We talked about it in part 1 of this unit. High levels of cortisol seem to blunt leptin response, and cortisol can become chronically high in the early stages of dysregulation of the stress response. Insulin resistance is another causal factor, and so what we have here is a vicious circle, because leptin resistance is certainly connected with the development of insulin resistance over long periods of time, perhaps decades. So really the bottom line is that too much sugar and carbohydrate in the diet, and especially fast-releasing sugar and carbohydrate, is really at the root of the problem. But also we've got inflammation. Inflammation blunts the leptin response. Inflammation's a key topic in brain health, and we'll cover it later in its own unit, in Unit 8 of the course. And yes, your genes can predispose you to leptin resistance, but remember what we've been saying, genes are only blueprints, and most genes are switchable, typically by diet and lifestyle factors. So genes certainly don't seal your fate, as it were. We'll finish by summarizing what we've covered in this presentation. We've looked at the thyroid gland. It controls the rate at which we burn energy, and low function of the thyroid system can lead to fatigue, weight gain, brain fog, and mood problems. There's a lot of controversy over the diagnosis of thyroid problems, mainly because thyroid disorder is a matter of degree and can range from clinical to subclinical. Thyroid problems can also be functional, rather than as the result of damage to the gland itself. For most non-medical, everyday cases of fatigue, brain fog, etc., thyroid testing is probably not the first place to go. It's probably a second line of testing. Vitamin D is a signaling molecule. It's functionally a hormone, has wide-ranging effects, and deficiency is common and correlates to lots of major chronic health problems, including several things that relate to the brain, such as depression and anxiety. The key thing is to get the blood concentrations up into the optimal range, and for that reason vitamin D testing is really so important. Lastly, we looked at appetite regulation, a complex topic, But from a practical point of view, the key seems to be blood sugar regulation, that is, keeping blood glucose levels stable. So insulin resistance and adrenal dysregulation, because of their relevance to blood sugar regulation, they're significant causal factors in appetite dysregulation and problems with craving.